Welcome to the module Head, Neck, Adult Central Nervous System, and Thyroid Malignancies. My name is Dr. Kelly Fritz, and I'm the Oncology Clinical Coordinator at Huntsman Cancer Institute in Salt Lake City, Utah. This presentation is part of the ASHP, ACCP, BCOP Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive, with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures are displayed on this slide. The presentation learning objectives are listed here. There are some objectives that will not be discussed during this presentation due to the time allotted. These are the objectives that are listed in the handout only. Please look to your handout for information on these items. We will first discuss head and neck cancers. Head and neck cancers are a heterogeneous mix of mainly squamous cell carcinomas located in the following areas: oral cavity, nasopharynx, oropharynx, hypopharynx, larynx, and the sinuses. Most patients present with locally advanced disease, and medical management is similar for oral cavity, oropharyngeal, hypopharyngeal, and laryngeal cancers. Nasopharyngeal tumors, the sinonasal tumors, and salivary gland tumors are treated with different chemotherapy. We will mainly discuss the HPV-associated cancers, which are most commonly associated with oropharyngeal tumors. And nasopharyngeal tumors are usually EBV positive. But we will talk about the HPV tumors for the majority of this session. In the last 30 years, the overall risk factors for head and neck cancers have shifted from mainly alcohol and tobacco related to HPV related. This increase is thought to be due to a latency period of about 10 to 30 years from exposure to development of malignancy. And as you can see now, about 70% of specifically our oropharyngeal tumors are HPV positive. Like I said before, the HPV related cancers are mainly found in the oropharynx. So we're seeing them in younger patients who have not used tobacco or alcohol, and we see a different genetic profile. When we look for HPV positivity, we're actually testing for P16 immunohistochemistry. And this is a requirement for anyone who has a diagnosis of an oropharyngeal carcinoma. So these patients actually have a more favorable outcome and favorable prognosis. And as of right now, there are some testing and some studies that are looking towards possibly changing how patients are treated. But as right now, the staging is sort of separate, but not necessarily the treatment. So now we're going to talk about our first patient and knowledge check. AG is a 50-year-old gentleman with a new diagnosis of locally advanced squamous cell carcinoma of the tonsil. He has used chewing tobacco since age 12 and only has occasional alcohol use. His P16 immunohistochemistry is negative, indicating negative HPV status. Staging scans revealed no distant disease, but multiple positive lymph nodes, so he underwent resection of his tumor. Pathology after surgery showed positive margins. Which of the following is the most appropriate for this patient at the time? A, concurrent radiation with weekly cisplatin. B, concurrent radiation and every 3 weeks cisplatin. C, concurrent radiation with weekly cetuximab. Or D, docetaxel, fluorouracil, cisplatin, and then resection. And I'll let you have a moment to think about your answer, and we'll discuss which one is correct. The correct answer is B, concurrent radiation and every 3 week cisplatin. We'll talk about the differences between every 3 week cisplatin and weekly cisplatin in the coming slides. Concurrent radiation with weekly cetuximab is no longer favored in the NCCN guidelines. And then docetaxel, fluorouracil, cisplatin, and then resection is also an incorrect answer. Like our patient AG, about 60% of head and neck tumors will present at a locally advanced stage. And then we have distant metastatic patients have generally poor overall survival, similar to our other types of tumors, and that number varies greatly dependent on other comorbidities. We will mainly focus on discussing locally advanced and distant disease in this lecture, but you can find some information on local disease in your handout. The mainstay of treatment for locally advanced head and neck cancer is surgery and/or concurrent chemoradiation. So it can be definitive on its own or adjuvant after surgery. And usually it's added adjuvantly if a patient has some sort of high-risk feature, which includes extranodal extension, positive or close margins, multiple positive lymph nodes, nodal disease at certain levels in the neck, or perineural lymphatic and or vascular invasion in the tumor. This adjuvant chemoradiation is added mainly for local and regional relapse benefit, and there is also an overall survival benefit compared to radiation alone. NCCN prefers and is a category recommendation for single agent cisplatin, and they stress the importance of the high dose cisplatin, 100 milligrams per meter squared every 3 weeks versus the 40 milligrams per meter squared weekly. The high dose cisplatin every 3 weeks was compared to 30 milligrams per meter squared weekly in a randomized controlled trial by Neurona and colleagues. And this showed actually a benefit for the higher dose cisplatin, and this is why NCCN makes it a category 1 recommendation. And so every 3 week is definitely superior, even though it is more toxic. Sorry, that slide is incorrect as well. It should be more toxic. Mohammed and colleagues did a meta-analysis comparing 100 milligrams per meter squared every 3 weeks to 40 milligrams per meter squared weekly during radiation, and they had comparable efficacy and safety. So the main study did the lower dose of cisplatin weekly, but NCCN recommends the higher dose 40. However, it wasn't done in a head-to-head randomized controlled trial, so NCCN still recommends the 100 milligrams per meter squared. There are a lot of centers that do 40 milligrams per meter squared weekly because of toxicity, and it is a category 2B recommendation. So the benefit of the cisplatin is really seen in someone who gets 2 doses. So we want a cumulative cisplatin dose of greater than or equal to 200 milligrams per meter squared during radiation. In the locally advanced disease treatment section in NCCN, there is a section for induction chemotherapy. So think about induction chemotherapy as neoadjuvant therapy. In general, it's very poorly recommended for most head and neck cancer subtypes. But for the hypopharyngeal or laryngeal tumors, for certain tumor sizes, it is a category 2A recommendation because there is a preservation strategy for the larynx if you do neoadjuvant or what's called induction chemotherapy. The problem is that it's a very toxic regimen. So it's usually a taxane plus cisplatin and 5-FU. So the regimen's called TPF. And most of the time these patients can't get high dose cisplatin with radiation afterwards because they have such high toxicity concerns, mainly because of the cisplatin component. So in those cases, you would do a weekly cisplatin or a weekly carboplatin. But again, not recommended for majority of the head and neck cancer subtypes, just for hypopharyngeal or laryngeal tumors. Okay, for our second audience response question, AG, our patient from before, he comes in for surveillance scans a year later and is found to have a new right lung lesion. Biopsy of this lesion proves recurrent squamous cell carcinoma, and genetic testing reveals PD-L1 combined positive score of 50. What is the most appropriate therapy for AG at this time? A, cetuximab fluorouracil cisplatin, B, pembrolizumab fluorouracil cisplatin, C, cisplatin and paclitaxel, or D, nivolumab. And I'll give you a second to think about your answer. The correct answer is B, pembrolizumab fluorouracil and cisplatin. The other semi-correct answer could be cetuximab fluorouracil and cisplatin, and we'll talk about these 2 regimens later. Metastatic and recurrent disease therapy has changed in the last couple of years with the addition of nivolumab and pembrolizumab, mainly in the second line setting. And these patients don't necessarily have to have PD-L1 positivity. But for our first line regimens, we'll talk about the 2 studies. But for non-nasopharyngeal tumors, we have the cisplatin, carboplatin, 5-FU, and cetuximab combination. And then we have the cisplatin, carbo, 5-FU, and pembrolizumab combination. Pembrolizumab can also be used alone if the CPS is greater than 20. For the second line setting, you can use a variety of single agent chemotherapies, and it's really about patient fit. And then there's always an option for palliative radiation if needed. The EXTREME trial looked at both chemotherapy and cetuximab, and the addition of cetuximab to that chemotherapy in untreated recurrent or metastatic squamous cell carcinoma of the head and neck. Obviously, these are non-nasopharyngeal tumors. So it was the same chemotherapy, so cisplatin or carbo plus 5-FU, and then the addition of cetuximab afterwards. And with the addition of cetuximab, there was an increase in overall survival and progression-free survival and a higher disease control rate. So this really put this regimen on the triple drug regimen as a NCCN Category 1 recommendation for metastatic head and neck cancer. The KEYNOTE-48 trial was completed just a couple of years ago and included pembrolizumab. And so this study looked at pembrolizumab alone, pembrolizumab plus platinum and 5-FU versus the extreme drugs, so cetuximab, platinum, and 5-FU. Overall survival superiority was tested sequentially for pembo plus chemo versus cetuximab plus chemo in the PD-L1 CPS greater than 20 and then the CPS greater than 1 population. Overall, the KEYNOTE-48 trial showed that compared with cetuximab and chemotherapy, pembrolizumab chemotherapy had superior overall survival in all three groups: median CPS greater than 20, CPS greater than 1, and the all-comer population. The overall response rate was numerically higher in those with a higher CPS score. In our pembro alone arm versus the extreme, we do see an increase, statistically significant increase in median overall survival with CPS greater than 20 and CPS greater than 1. However, all comers, when they looked at that in median overall survival, it was not statistically significant. The authors do comment that although they did not do statistics specifically on the median duration of response, patients in the pembrolizumab alone group had numerically higher durations of response if they were CPS or PD-L1 positive. These overall results of the KEYNOTE-48 trial do support the pembrolizumab and pembrolizumab chemotherapy as new first-line standards of care for recurrent or metastatic head and neck cell carcinoma. We're now switching patients, but we have a third audience response question. So AK is a 66-year-old man who comes into the clinic for chemotherapy counseling. He'll be starting cisplatin and radiation for locally advanced oropharyngeal cancer. He is a current smoker. Based on recommendations from the MASK guidelines, what would you counsel him on regarding mucositis prevention? A, he will receive amifostine prior to each cisplatin, so he won't need to do anything at home. B, he will need to swish and spit with doxepin solution before each radiation treatment. C, he will need to swish and spit with salt and soda solution. Or D, he will receive dexamethasone swish and spit prior to each cisplatin, so he won't need to do anything at home. Please review the question and answer result options, and then we'll talk about that in a second. The correct answer is C. He'll need to swish and spit with salt and soda solution as a preventative measure. So we'll talk about this a little bit more, but doxepin and dexamethasone are more for treatment of mucositis and for different regimens, and amifostine is not recommended for mucositis prevention for cisplatin. So head and neck cancer patients do develop a good amount of mucositis, and so this is our supportive care section for the head and neck lecture. This also includes information on other disease states, but please look to your handout for more information on overall care and treatment of mucositis. Risk and development of oral mucositis is based on both patient risk factors and the disease risk factors. So things like current smoking and tobacco use, overall baseline hygiene, age, female sex, pre-treatment nutritional status are the patient risk factors. The disease risk factors, so patients that are head and neck cancer patients are a high risk, whether it's chemotherapy versus radiation versus the combined treatment. So combined typically has a higher risk. Doses of therapy and frequency of therapy will definitely increase the risk of oral mucositis development. Development of oral mucositis can cause significant morbidity and mortality. So very high risks of malnutrition, infection, and even death. Can cause some delays or dose reductions in chemotherapy, definitely decreasing their overall chance of responding to therapy, and can be considerably financially toxic for these patients. MASC, or the Multinational Association of Supportive Care in Cancer, developed guidelines for treatment and prevention of oral mucositis. So they give recommendations for use for certain patient groups, and then suggestions for use, suggestions against use, guidelines for certain medications. So for recommended for use for 5-FU specifically is oral cryotherapy, so chewing on ice. They also recommend benzoamine mouthwash. Unfortunately, this is not approved in the US, so it's great because it's used in other nations, but unfortunately we can't use it here. For specific patient groups, we have like the stem cell transplants, we have pilifermin, specifically for autologous transplants, low-level laser therapy, and intravenous morphine. And then other suggestions for use: oral care protocols, doxepin, zinc supplements, other cryotherapy, fentanyl patches, morphine, and laser therapy for head and neck cancer. The MASC guidelines are great to give us recommendations on medications, but we really need to look at the practical management of these patients. So the best thing is to try to prevent the formation of oral mucositis. So that's recommending good oral care, so using a soft toothbrush, using bland mouth rinses, having a formal dental assessment before a patient starts therapy, using cryotherapy, having significant diet modifications, so no chips or very sharp foods, avoiding anything really starchy or acidic, and then avoiding alcohol. And then for certain types of patients, we would even put in a prophylactic percutaneous endoscopic gastrostomy tube, so a PEG tube for feeding. So they just basically, even if they get mucositis, they can still have good nutrition throughout their therapy. And then when a patient finally develops mucositis, we really want to think about a couple of things. So one, level of pain. Is it something that needs to be treated as an inpatient, or can they do it at home? Are they able to tolerate anything oral? So solid foods, or are they full liquid, or can they not even tolerate that? Are they at any risk for any secondary infections? Or do they already have a secondary infection? And then really, what's the integrity of the mucosa? So is it white? Is it red? Is it bleeding? Are there lesions? All of these things we should really inquire about. And then, like I said before, in terms of pain, can the patient really handle this at home? Are they able to really deal with some of these significant medical issues at home? And then we kind of go from there. So as a practical management for our chemotherapy-induced mucositis, really we should start from our saline-based rinses and possibly a viscous lidocaine rinse to some of these more intensive regimens when the symptom severity goes up. So prevention with saline rinses, maybe a little bit of treatment at home with some viscous lidocaine, and doing diet modifications, then doing low-dose morphine rinses, and then if it's so severe, really admit the patient to the hospital and do a systemic opiate, usually like a patient-controlled analgesia. In radiation-induced mucositis, we can add a couple more therapies here. So prevention with saline-based rinses and lidocaine, using things like gabapentin, and this low-level laser therapy is now indicated for certain types of head and neck cancers. Then we do a topical oral morphine rinse, then a doxepin rinse, and then again, still ending up with these systemic opiates and a PCA when the patient's admitted, as these symptoms get worse and worse and worse. For oral mucositis caused by targeted agents, mainly our mTOR inhibitors, and this is often caused stomatitis. You still use the saline-based rinses, and then this is where we really get into our corticosteroids. So you can start with a dexamethasone mouthwash, and then as symptoms increase, you can also use systemic corticosteroids. And not to forget our gastrointestinal mucositis. So this is where the amifostine actually fits in. So this is recommended to prevent radiation proctitis in patients receiving radiation treatment for rectal cancer. And then for our significant diarrhea, gastrointestinal mucositis, this is where the octreotide IV comes in if someone is unresponsive to loperamide. For esophagitis during chemoradiation, another suggestion for use is the amifostine. However, I don't think a lot of people actually use it. And then there's a few suggestions for use of sucralfate enemas, sulfasalazine, probiotics, and then hyperbaric oxygen. Even though these head and neck cancer patients don't have a lot of chemotherapy options, there's a lot we can do as pharmacists because there is a significant amount of supportive care we can give them. So things like nutritional assessments at baseline, we can place enteral feeding tubes, especially for someone who is at extremely high risk of morbidities from mucositis or just where their tumor is, especially those undergoing concurrent chemoradiation. Having a patient do speech and swallowing assessments because of location of tumor, having a dental assessment, psychological evaluations, and then these patients also, especially our non-HPV positive tumors, are usually smokers or alcoholics and could definitely utilize a cessation counseling session. And there's more info on the handout about smoking cessation. In summary, for head and neck cancers, they're a heterogeneous group of tumors, majority being squamous cell carcinomas. Our nasopharyngeal tumors, remember, are treated slightly differently. More information about that is in the handout. Most patients present with locally advanced disease and are treated with definitive chemoradiation with high-dose cisplatin. The metastatic or advanced disease patients are controlled with multimodal therapy and with all this new information supporting using first-line immune therapy, which is very exciting. And these patients require a significant amount of supportive care throughout their therapies. Our next topic of the day is thyroid cancer. And we'll start with a patient case. So CA is a 65-year-old woman who noted intermittent difficulty with swallowing and voice hoarseness. She had a CT angiogram that showed a 2.3 by 2 by 3.6 centimeter left thyroid mass. On biopsy, it was shown to be differentiated thyroid carcinoma. A total thyroidectomy was then performed, and the pathology confirmed papillary thyroid carcinoma, or PTC. 6 of 33 lymph nodes were positive in the left neck, and a left tracheal resection showed papillary thyroid carcinoma as well. Based on this information, CA has newly diagnosed papillary thyroid cancer with positive lymph nodes and extension into the trachea. What is the most appropriate therapy for CA at this time? A, observation, B, lenvatinib, C, radioactive iodine, or D, dabrafenib and trametinib. I'll pause for a moment for you to think about your answer. And the correct answer is C, radioactive iodine. So based on the amount of lymph nodes and the left tracheal extension, this patient is not appropriate for observation. Lenvatinib is used after radioactive iodine. And then dabrafenib and trametinib is specifically for patients with BRAF positive disease, mainly in the anaplastic thyroid area. So we'll talk about all of these options in the next coming slides. Thyroid cancer is divided up into 3 different histologic types. The first is differentiated thyroid cancer, and that is divided up into 3 further subtypes. So we have papillary thyroid cancer, which commonly has RET fusions or BRAF V600E and K mutations. We have the follicular thyroid cancers, which a lot of times have RAS mutations. And then we have Hürthle cell tumors, which is considered a variant of follicular thyroid cancer. However, these have a distinct histologic appearance and a unique genetic signature, and they are treated different and are typically a lot more aggressive than what we think about of our normal differentiated thyroid cancers. The second histologic type of thyroid cancer is medullary thyroid cancer. And a lot of these thyroid cancers have a RET mutation. And this is important since we now have new therapy for that. And then the rest of them are inherited. And all of these actually have a RET germline mutation. And then the third and final histologic type is anaplastic thyroid cancer. Unfortunately, these tumors, in terms of genetic signature, have some inactivation of PTEN and TP53, but usually do not have a lot of targetable mutations. And this is the poorest prognosis of our thyroid cancers, with disease-specific mortality of about 100% after a year or two. Anaplastic thyroid cancers can evolve from a prior differentiated thyroid cancer, usually by development of a bunch of genetic alterations. We'll first talk about our differentiated thyroid cancer treatment recommendations. So surgery is typically the mainstay of therapy, and that can be either a total thyroidectomy or a lobectomy. After surgery, patients can get radioactive iodine. And this really takes advantage of the thyroid's follicular cells and their ability to transport and incorporate iodine into thyroglobulin. And so this can help treat the tumor. And then our systemic therapy is typically reserved for radioactive iodine refractory disease. And these are where our tyrosine kinase inhibitors, sorafenib and lenvatinib, really fit into therapy. The goal of radioactive iodine is to ablate any of the normal thyroid tissue that's left. And so those patients where it's definitely recommended for is anyone who has gross extrathyroidal extension, larger tumors, or elevated thyroglobulin levels after thyroidectomy. The patients that it's not recommended for are those with classic papillary thyroid histology, small tumors, and basically no detectable thyroglobulin antibodies. There are some characteristics that would put you at higher risk. Some of the higher risk histologies like Hürthle cell, any lymphatic invasion, and some moderately high thyroglobulin levels. But really those radioactive iodine candidates are those that have extrathyroidal extension and larger tumors, because you want to ablate any of that micrometastatic disease. In those patients who are radioactive iodine refractory, we're really looking at our therapies with multikinase inhibitors. So the two that are approved for differentiated thyroid cancer are sorafenib and lenvatinib. Sorafenib was included in the guidelines after the Decision trial came out with progression-free survival of 10 months over placebo. And then they had an overall response rate of 12%. Those patients had only received radioactive iodine or chemotherapy versus the patients on the lenvatinib trial, which is the SELECT trial, could have been TKI naive or have had one prior regimen, which would be sorafenib. So both of these are options for patients who are refractory to radioactive iodine. However, NCCN does prefer lenvatinib because in the SELECT trial, there is a higher numerical overall response rate of 64% compared to the 12% in the SELECT trial for sorafenib. They both have similar general ADRs because of the multikinase nature of these TKIs. So they both have hand-foot issues, rash, diarrhea. However, sorafenib has hypertension and some hemorrhage risk. Lenvatinib, the hypertension is very significant. The other options after sorafenib or lenvatinib failure, you could try the other TKI. So if someone was on sorafenib, they could try lenvatinib and vice versa. If patients are RET fusion positive, selpercatinib is our new RET fusion medication. But really, these patients should go on a clinical trial. There are a lot of other off-label multikinase or VEGF TKIs that can be used, like pazopanib, axitinib, sunitinib, and vandetanib, and possibly everolimus. But as you can see, most of these are VEGF, RAS, or RET target. And I think the biggest thing to take away from the differentiated thyroid carcinomas is that cytotoxic chemotherapy is usually not effective. So you're probably not going to see that in anyone. It's going to be one of these targeted therapies. Okay, time for our next case. So this is J.A. He is a 67-year-old man who noted an enlarging mass on the right side of his neck. A total thyroidectomy was performed and pathology confirmed a medullary thyroid carcinoma. This lesion was 2.9 centimeters, and also he had multiple positive lymph nodes of the bilateral neck. He underwent surveillance for 3 years, but after continued elevation in calcitonin, he was started on vandetanib. According to the main trial supporting vandetanib use in medullary thyroid carcinoma, what was the most concerning side effect that brought about required REMS program for its use? A, fetal harm, B, prolonged QTC, C, GI perforation, or D, Stevens-Johnson syndrome? And I'll give you a second to think about your answer. And the answer is B, prolonged QTC. And that's now highlighted. So in terms of GI perforation, fetal harm, and Stevens-Johnson syndrome, those are black box warnings for other TKIs, but for vandetanib, it's actually prolonged QTC. Medullary thyroid carcinoma is going to be treated slightly differently than our differentiated carcinomas. So surgery is still a mainstay. It's a total thyroidectomy. You can do radiation for residual disease, but unfortunately, medullary thyroid carcinoma does not concentrate iodine 131. So radioactive iodine is not used for management of medullary thyroid carcinoma. So if you ever see that question, it is not a correct answer. So really, like our patient case, you kind of undergo observation post-surgery, and then on recurrence, we utilize systemic therapy. Very similar to a differentiated thyroid carcinoma, we use TKIs. So cabozantinib, vandetanib, and now selpercatinib are 3 medications that are utilized for systemic therapy for medullary thyroid carcinoma. Also, like our patient case, we can use calcitonin and CEA as tumor markers to look for biochemical relapse before maybe a patient has systemic side effects. So our 3 medications are vandetanib, cabozantinib, and selpercatinib. So vandetanib and cabozantinib, you don't have to have any type of mutation, whereas the selpercatinib, you need to have a RET mutation. So our selpercatinib is our new medication. It is 160 milligrams or 120 milligrams twice daily. These are with or without food. This medication was approved by the Libretto trial. And if you've listened to the lung cancer lecture, you've noticed that selpercatinib is also indicated for RET mutated lung cancer. But we're using it for thyroid cancer here, obviously, for medullary thyroid cancer. And so these patients who were either previously treated with a TKI or treatment naive had a great overall response rate. And so this medication is excellent for those RET mutated tumors. So going back to vandetanib and cabozantinib, again, both oral medications. Like I said before, the black box warning for vandetanib and the REMS program is this QTC prolongation and development of torsades. And sudden death from QT prolongation and torsades. So it's really important that and recommended that all electrolytes, calcium, magnesium, and potassium are repleted and corrected prior to initiation of vandetanib and obviously monitored. Vandetanib was approved after the completion of the Zeta trial with a PFS of 30 months and an overall response rate of 45%. And then the cabozantinib, main black box warnings here are perforation and fistula formations, and then also hemorrhage. This was approved after the exam trial with an overall response rate of 28%. So the exam trial, these patients were thought to be sicker with more advanced disease, probably explaining the differences in overall response rate and progression-free survival between vandetanib and cabozantinib. So unfortunately, none of these medications have been compared head-to-head. So really, if you have a RET mutation, you're going to use selpercatinib, and then the options between vandetanib and cabozantinib would be patient-dependent and then comorbidity-dependent. But most of these medications are all very similar in their ADRs because of the multi-kinase nature of the TKI. NCCN recommendations for metastatic or unresectable or recurrent medullary thyroid cancers are category 1 for vandetanib and cabozantinib. And here they don't necessarily have a preference like they did in the differentiated thyroid cancers. And then a category 2A is their selpercatinib if and only if those patients have a RET mutation. Like our differentiated thyroid cancers, really the preferred treatment after failure of one of those options is a clinical trial. You can also use other off-label multi-kinase TKIs like sorafenib, sunitinib, and pazopanib. And then here, dacarbazine is still included in the NCCN for recommendations. For a recommendation if you failed one of the TKIs. However, the overall response rate is abysmally low. And so most of the time you're going to use a targeted therapy agent. Our final thyroid cancer histologic type is our anaplastic thyroid cancer. So these are a very aggressive form of thyroid cancer, and they represent a very small percentage of overall thyroid cancer cases, only about 2%. The mean age is 70, and women make up 60 to 70% of these patients. Like I said before, the overall survival is very low. So 1 year overall survival is about 20%. And the median survival from diagnosis is about 5 months. And the majority of these patients present with local disease, and up to half of them already have distant metastases at diagnosis. There's no recommended first-line therapy for these patients. Really, it's multimodal. So surgery, radiation, any type of chemotherapy. Like our medullary thyroid patients, it doesn't concentrate iodine, doesn't express a TSH receptor or produce thyroglobulin. And really, the things to do up front is supportive and palliative care because we know these patients are not going to live very long. So our first-line therapies are really chemotherapy. So paclitaxel, carboplatin, docetaxel, and doxorubicin, single agent of either of those two. And these chemotherapy agents and combinations usually have a pretty low response rate, but something 10 to 20%. So really these patients should be referred to a clinical trial. And actually doxorubicin is the only FDA approved agent for anaplastic thyroid cancer. The only possible golden light that we've had in the last couple of years for anaplastic thyroid is the FDA approval of dabrafenib and trametinib. And this combination, obviously for those who have a BRAF V600E mutation and no satisfactory local regional treatment options. So this was a phase 2 open label trial, and it was only 16 patients. Again, this is a very low population of thyroid cancer patients. But there was an overall response rate of 69%, and seven of those responses are ongoing, which is unbelievable for this type of tumor. The adverse events were very similar to what we know about dabrafenib and trametinib, with fatigue, pyrexia, and nausea being the most common. So even though these patients have very poor prognosis, those who do have a BRAF V600E mutation at least have a targeted therapy option for their treatment. Most of these patients are going to have some sort of thyroidectomy, and afterwards we want to have TSH suppression. So they're going to be on some sort of thyroid agent like levothyroxine. So NCCN doesn't have a specific goal. However, based on their risk of recurrence, we have some general TSH goals. So we actually suppress them pretty much, especially if they have known residual cancer or at a very high risk for recurrence. And then a slightly higher low level of normal for those with some risk of biochemical disease, but no disease on imaging. And then basically everyone else is in the lower limit of the reference range. As a reminder, people on TSH suppression should be counseled to take calcium and vitamin D, if not adequately obtained through their diet. Again, this is mainly with patients with differentiated thyroid carcinoma. Medullaries and our anaplastics don't really respond to TSH. So in those patients with post-thyroidectomy, they should just be on supplementation doses to keep their TSH within the normal range. In summary, for thyroid cancer, there's 3 main histologic subtypes. We've got differentiated, medullary, and anaplastic. And all of them have different treatment strategies. So our differentiated and medullary can use TKIs, but for our differentiated cancers, really our first-line therapy is radioactive iodine and then a TKI for refractory. Our medullaries, they don't concentrate iodine, so no radioactive iodine. Selpercatinib is our new agent, and then our other TKIs for advanced disease. And then anaplastic thyroids are poorest prognosis, limited treatment options, mainly chemotherapy, and our BRAF inhibitors, BRAF-MEK inhibitor combination if BRAF V600E positive. Moving on to our central nervous system cancers. So for the presentation today, we'll just be talking about the lymphomas, the CNS specific lymphomas, and our gliomas. There are a couple other types of central nervous system cancers in adults, but please refer to your handout for information on those tumors. CNS tumors are classified slightly differently than our other types of tumors. So if you think about it, most of these tumors actually don't metastasize outside of the CNS. So instead of having stages, there's grades. The WHO has an extensive classification list based on histology and now molecular pathology to divide these cancers, these tumors, up into grades. And most of our other CNS tumors are kind of divided up like this. So grade 1s are very uncommon in adults, but we're really looking at grade 2s, grade 3s, and grades 4s of gliomas. Most of them are divided up into an oligodendroglioma histology pattern or an astrocytoma histology. And further then looking at some of these mutational histology patterns. So for an oligodendroglioma, they are typically 1p19q co-deleted, IDH mutated, and MGMT methylated. Our astrocytomas are 1p19q intact. IDH can be mutated or wild type, and then MGMT mutated or methylated or unmethylated. The differentiation between grade 3 and grade 4 has gotten a little bit murkier in the last couple of years. Our traditional grade 4 glioma is a glioblastoma, and these are typically IDH wild type, MGMT unmethylated, and EGFR non-amplified. What we've seen now is that these IDH wild type astrocytomas with a grade 3 histologic pattern typically behave like our grade 4 glioblastomas. And so you'll see that IDH wild type anaplastic astrocytomas are typically clumped in with our glioblastomas and are treated very similarly. So in terms of classification nomenclature, grade 2s are typically noted as diffuse, grade 3 are typically noted as anaplastic, and our grade 4 are just either glioblastoma or an IDH wild type anaplastic astrocytoma. These different grades of glioma are treated slightly differently, whereas our grade 2s have a much better prognosis, grade 3s dependent on the histology, and our grade 4 glioblastomas have a very poor prognosis. Looking specifically at our different types and different molecular pathology indicators, we have our co-deletion of 1p19q, and this is basically just associated with an oligodendroglioma, because historically the oligodendrogliomas do well and have a better prognosis. This is associated with a favorable prognosis. If someone is not co-deleted or just 1p deleted, that means that it's an astrocytoma, not an oligodendroglioma. Moving on to our IDH, so you can have mutations in both IDH1 and IDH2, and that is isocitrate dehydrogenase 1 and 2. And mutations in either of these result in a formation of an oncometabolite, 2-hydroxyglutarate, and this increases DNA hypermethylation, which prevents differentiation. Mutations in these actually make tumors slightly more responsive to therapies, radiation and chemotherapy, and is typically seen in our lower grade gliomas, so grade 1 and grade 2s. This is a favorable prognostic indicator and probably the most important prognostic indicator that we have right now for gliomas. And so mutation in either one of these is a very, very favorable thing. And especially even in our glioblastomas, if you have a mutation in IDH, you do have prolonged survival compared to someone who has a wild type IDH. I also talked about MGMT promoter methylation. So MGMT is 0,6-methylguanine DNA methyltransferase. And if this promoter region is methylated, it prevents the repair of DNA damage, including from alkylating agents. And one of our most common alkylating agents that we use in gliomas is temozolomide. So the methylation of this MGMT promoter is a positive predictive marker for response to temozolomide. Again, still positive prediction, not necessarily as much as IDH. And for the most part, anyone who's IDH mutated is almost always MGMT methylated, but not necessarily the other way around. So you can be MGMT methylated in IDH wild type, but this still confers a generally positive prognosis because you're more likely to respond to our temozolomide therapy. And then finally, there's EGFR alterations in gliomas. So EGFR amplification and a mutation are seen in about half of our glioblastomas, generally a poor prognostic indicator if you're mutated or have amplification. However, any EGFR targeted therapies have pretty much failed miserably in trials in our glioblastomas, so they are not used to direct treatment, but are possible additions in clinical trials. Now for our next audience response question. So Gigi is a 42-year-old man with a new diagnosis of anaplastic oligodendroglioma of the right temporal lobe. He underwent a subtotal resection, and mutational analysis showed 1p19q co-deletion, IDH mutation, and MGMT methylation. What is the most appropriate therapy for Gigi at this time? Observation: B, radiation followed by procarbazine, lomustine, and vincristine. C, temozolomide with concurrent radiation. Or D, temozolomide with concurrent radiation followed by temozolomide. And I'll give you a second to think about your answer. And the correct answer is B, radiation followed by procarbazine, lomustine, and vincristine. Based on the age of our patient and the subtotal nature of his resection, observation is not appropriate. Temozolomide with concurrent radiation alone is not recommended because the adjuvant temozolomide actually does improve survival. And then temozolomide with concurrent radiation followed by the adjuvant temozolomide is definitely an option. However, the correct book answer per NCCN and available data is radiation followed by the regimen procarbazine, lomustine, vincristine, or PCV. So like I said, our grade 2 are what we call diffuse or low-grade gliomas. They can be either astrocytoma or oligodendroglioma. Surgery in these patients is very predictive of survival and also used for tissue acquisition and diagnosis. But the goal for any of these tumors is maximum safe resection. And so since you're dealing with the brain and we worry about eloquent areas of the brain, sometimes not all of these tumors can be fully resected. For radiation, there's really no consensus whether it should be done immediately or at the time of recurrence. These patients can live for multiple years, and especially if they don't have high-risk factors, which we'll talk about, you can actually wait after surgery and they can just go under observation. So for chemotherapy, the recommendation is a category 1 in NCCN, and that is for the PCV regimen. And this can be either or pre-radiation or post-radiation. You don't do this combination with radiation because of toxicity. But the 3 drugs are procarbazine, lomustine, and vincristine, which is probably the only area that you'll see some of these old drugs used. It's a 6-week cycle, mainly because of the lomustine. And if anyone has a high-risk feature, this is when we actually try to use this. So our patient was older than 40 and had a subtotal resection. We would want to do this therapy after surgery instead of waiting. Those who are less than 40, and had a gross total resection can just undergo observation. So in the trial by Buckner and colleagues in 2016, they had patients that had these high-risk features versus low-risk features. And we had a pretty significant increase in overall survival, progression-free survival, and overall survival with the addition of PCV compared to radiation alone. Unfortunately, PCV and Temodar have not been compared head-to-head. So in terms of NCCN and the information available, PCV is the preferred option for our low-grade gliomas with high-risk features. Moving on to our grade 3 or anaplastic gliomas. So that's an IDH mutated astrocytoma or just an anaplastic oligodendroglioma. Still a small subset of our malignant gliomas, and still goal of surgery is to obtain tissue, have a maximum safe resection to improve overall survival. And then same thing for radiation. It is highly recommended because of the anaplastic nature. We don't wait for these patients to recur. We usually do it right after surgery. And like our grade 2 gliomas, those that have an oligodendroglioma histology, again, usually has a better prognosis. Radiation and PCV is our standard of care, and this is an NCCN category 1 recommendation. Our anaplastic astrocytomas, so we'll talk about the IDH mutant ones because our IDH wild type ones are considered grade 4. Adjuvant temozolomide with radiation, and then followed by temozolomide is our preferred option. If radiation is deferred for some reason, then you can do either one. The problem is, and we'll talk about this with the STOOP trial in glioblastoma, is that we don't really know the duration of temozolomide for anaplastic astrocytomas. Most providers do 6 or 12 months, and the information available from these trials is really to do 12 months for these anaplastic IDH mutant astrocytomas. And then for both of them, salvage therapy is usually temozolomide or another chemotherapy, PCV, as possible once they recur. Now we're into our grade 4 gliomas or glioblastomas. This is the most common malignant brain tumor in adults, and this represents more than half of them in all of gliomas. So our biggest prognostic factors, like what we talked about, is molecular pathology. And then this is when age, performance status, extent of resection, and any type of symptoms that they had pre and post surgery are very important. So our surgery, again, because these tumors are extremely diffuse, very infiltrative, it's really gross total resection does have better prognosis, but you don't want to sacrifice a surgery into a very eloquent area of the brain just to get a gross total resection. There is data, and carmustine wafers or BCNU wafers can be put into the surgical cavity. However, most of these patients cannot undergo clinical trials and could have potentially increased side effects with chemotherapy. So systemic chemotherapy after surgery, this is not a preferred treatment option. It is an NCCN category 2B recommendation. And then finally, radiation chemotherapy are really to improve overall survival and can be used alone or in combination, depending on the patient's performance status. The STOOP trial is the combination of temozolomide and radiation, and it's our standard of care for our glioma patients and many of our lower grade gliomas as well. So this combined temozolomide and radiation, followed by temozolomide alone for 6 cycles. There was improved 2-year overall survival compared to radiation alone in these patients. And then those with MGMT promoter methylation had improved benefits over those unmethylated patients. However, NCCN does recommend that this regimen is used in the unmethylated patients because there really isn't any other treatment options for those patients. And then these people can also use alternating electric field therapy. More information is in your handout about that, and that's usually administered during the adjuvant portion, the monthly cycles of the temozolomide. And as a reminder, the patients undergoing Temodar and radiation do need prophylaxis for pneumocystis because of increased rates of that during that portion. Those patients who are greater than 70 or have a poor prognosis can be offered hypofractionated radiation, and usually that's a 3-week radiation period instead of 6 weeks, like the STOOP trial. Unfortunately, at disease recurrence, there is no standard of care. We have bevacizumab plus or minus chemotherapy. You can do Temodar again, lomustine or carmustine PCV, and then newly added to the guidelines is regorafenib based on the Glioma trial, and that compared lomustine versus regorafenib. There was an increase in median overall survival. However, adverse events were pretty significant between both of them. So without really making sure that the patient has a good performance status, we probably would not recommend regorafenib. And truly a clinical trial is preferred at this point. Our last disease topic of the day is primary CNS lymphoma. So this is a very small portion of our primary CNS tumors, about 3 to 5%, and the incidence has increased pretty significantly over the past 2 decades, partially due to HIV infections. These are aggressive B-cell non-Hodgkin's lymphomas, and they basically do not have any systemic disease. Most of these tumors involve brain parenchyma. Leptomeninges and ocular involvement do include that other small portion, and those are not considered to be systemic. That is still part of the CNS. But a lot of these patients have involvement in either 2 or 3 of those areas. Like I said, there's increased rates of these types of tumors because of HIV, but it's usually seen in any immunocompromised patient. So whether it's HIV post-transplant or infection with Epstein-Barr virus. In terms of management of primary CNS lymphoma, just like systemic lymphoma, chemotherapy is a very big piece of treatment. Surgery and radiation are pretty limited. Surgery is mainly to confirm the diagnosis of diffuse large B-cell, and then radiation really is limited for those who have failed a lot of chemotherapy because it has such a high rate of neurotoxicity because you're radiating most of the brain. Our chemotherapy is high-dose methotrexate based, and it's usually combined with other chemotherapy. And then rituximab is added for CD20 positive tumors, and the majority of them will be CD20 positive because the addition of rituximab has been shown to improve response rates and causes minimal neurotoxicity. The important thing to note is that we should limit the amount of corticosteroids before diagnosis is confirmed because it can make the diagnosis in terms of histology difficult, just like our systemic lymphomas. And to wrap up our CNS tumors, our gliomas have a very disparate clinical course, and it's mainly influenced by the molecular biology and histology and the extent of surgical resection allowed. Radiation and temozolomide is our first-line therapy for glioblastoma. There are limited second-line therapy options, and our CNS lymphomas, it's a rare subset of CNS tumors, and high-dose methotrexate is our backbone of treatment. So that concludes this presentation. Thank you so much for participating.